Good afternoon, colleagues. I'm Clare Bambra, Professor of Public Health at Newcastle University, and I'm delighted to be invited to speak to you today about research that myself and colleagues in the NIHR School for Public Health Research have been doing, examining the interaction of COVID-19 and health inequalities, and how it is an unequal pandemic. Today I'm going to talk through this research and I'll talk a bit about some of the epidemiology of inequalities in COVID-19, particularly focusing on the first wave. I'm then going to put this in the context of what we know about past pandemics, including the Spanish flu of over 100 years ago. I'll then argue that what we're seeing with COVID-19 is a syndemic pandemic, where we're getting the interaction of pre-existing social inequalities and long-term conditions with a new emergent infectious disease. I'll talk through some of the pathways whereby COVID-19 is having unequal outcomes, and I'll reflect slightly on the new vaccine rollout as well, before concluding by thinking of what we need to do as a public health community to avoid such inequalities in the future. So firstly, there's been a lot of data released nationally by the government and analysis done by colleagues across the public health community, which have all demonstrated significant inequalities in COVID-19, both in the United Kingdom and in countries such as the US, Sweden, and India. Here we can see, for example, that during the first wave at the neighbourhood level, there was an almost twofold mortality rate in terms of COVID-19 and all-cause mortality in the 30% most deprived neighbourhoods compared to the least deprived. And to put that in context, during the first wave through to June 2020, then for example in Scotland, the death rate was 86 per 100,000 in the most deprived 20% and 38.2 in the least deprived, so around a twofold rate. And you can see similar in England and in Wales, and indeed in other countries. We've also noted significant regional inequalities. Again, this data relates to the first wave of 2020. Some research I was involved in with the Northern Health Science Alliance analysed the mortality rates from COVID-19, comparing the three northern regions, North East, North West, Yorkshire and Humber, compared to the rest of England. And we found that the mortality rate was around 12.5 per 100,000 higher in these northern regions compared to the rest of England. This is also underpinned and supported by research done by colleagues in the University of Liverpool, where they've done an index looking at vulnerability to COVID-19, focusing on factors such as ethnicity, poverty, and overcrowded houses and long-term conditions. And in their analysis, they also found that there were high levels of vulnerability and worse outcomes in the Northwest, the Northeast, and also the West Midlands. We can also see inequalities when looking at individual levels of socioeconomic status. So, for example, here's some data from Public Health England that analysed inequalities in terms of COVID mortality rates by occupation, and we can see big differences between people in more managerial and professional occupations, both amongst men and women, compared to people who are in more elementary or retail-facing work. And there's also very significantly been high ethnic inequalities in the COVID-19 pandemic, with case and mortality rates up to 3 times higher in some of our ethnic minority groups, for example, Black British, particularly amongst men. This, though, should perhaps not be a surprise when we take a more historical perspective, and we can look back onto past pandemics and see that actually we had similar inequalities. For example, in the 1918 Spanish flu pandemic, data from countries as diverse as Norway, Sweden, the US and England and Wales all report incidents of historical inequalities, with mortality rates much higher amongst the working classes, the unemployed and lower occupational groups, and also a significant urban-rural divide in England and Wales, with mortality rates 30 to 40% higher in urban areas during the Spanish flu pandemic. Again, mirroring what's happening with COVID-19, some work I led was examining historical data on Spanish flu mortality and looking at the regional impact. And again, we can see here in the map how the North and the Midlands were much more affected by mortality in 1918, just as they have been with COVID-19. And in the table, you can see some parts of the country 100 years ago that were most affected. Again, the worst death rates were those in the northern areas, particularly in areas of Durham and Tyne and Wear, where the death rates are almost 6 times higher, for example, than in those parts of the country, such as Sutton in Surrey, that had the lowest death rates. So there are these ghosts of past pandemics, these hints that we would see inequalities this time as we have done previously. And again, looking more recently, then we can look at the 2009 H1N1 swine flu, the kind of pandemic that wasn't, in a sense that it was well controlled. And we can see that data from Rutter and colleagues shows that mortality in England was 3 times higher in the most deprived neighbourhoods compared to the least deprived. Again, these patterns of being higher in urban compared to rural areas. And data also reinforces this from countries such as Canada, where hospitalisation rates were higher from people from lower educational or high deprivation areas. And again, data from the USA suggesting associations between people with financial difficulties and contracting H1N1. So there are these parallels that we can see. Together with colleagues from Newcastle and Cambridge within the School for Public Health Research, I wrote an article arguing that what we're seeing with COVID-19, with the inequalities now and indeed the inequalities 100 years ago, is a kind of toxic interaction of existing inequalities, the vulnerabilities demonstrated by the Liverpool Index, and the new emergent infectious disease. And drawing on the work of the anthropologist and clinician Meryl Singer, I've argued that this is a syndemic pandemic in which a set of closely entwined and mutually enhancing problems come together in a kind of configuration that is noxious in terms of outcomes and draws upon the damaging social conditions and social inequalities that exist before, during, and unfortunately after the pandemic. And we've argued that this is a syndemic when we think about COVID-19, long-term diseases and their interaction with the social determinants of health. I think there are at least 4 pathways where we can see and explain the inequalities in COVID-19. The first one is the increased vulnerability of people living in more deprived communities. So they already have a higher burden of NCDs, in turn related to their previous exposure to the social determinants of health. Secondly, there is an increased susceptibility with immune systems that have been weakened by long-term exposures to adverse living and environmental conditions, potentially making them more vulnerable to severe infection and potentially mortality from COVID-19. Indeed, studies of seasonal flu suggest that people from more deprived backgrounds, their immune system has a lower response to the pandemic. Thirdly, we can think about increased exposure. So looking particularly at inequalities in working conditions, particularly during the lockdown periods when people from lower income jobs were still often required and needed to be in their work, working with each other face to face, be it in factories or be it in essential retail and health and care sector. In contrast, people from more professional, managerial and office-based jobs were able to work from home and be significantly less exposed to the virus. And fourthly, we need to think about increased transmission. So how the inequalities in housing conditions, again part of the Liverpool Index, how these lead to inter-family, inter-household transmission, for example, through overcrowding, through difficulties in self-isolating within the home, and of course difficulties within urban and densely populated neighbourhoods in terms of being able to exercise and so on outside. We also need to think about some of the financial aspects of the way in which transmission and exposure might be happening and the inequalities within that in terms of things like the adequacy of sickness absence pay for people who need to self-isolate, who have a positive test, and whether indeed it's financially viable for them to do so or whether they return to employment. Again, something which happened over 100 years ago, where people working in factories might only take a few days off and still to return to work when they were highly infectious, and indeed would often succumb to the disease themselves and also spread it amongst their co-workers. So I think there are at least these 4 pathways that we analysed in our paper from last year. In addition to that, I think we also now need to think about a potential 5th pathway. The NHS vaccine rollout in the UK has been absolutely amazing, and it's clearly giving us a much better chance of beating COVID-19 and indeed the inequalities that it has produced. However, we also need to be mindful of what we know from other immunisation programmes, particularly the seasonal flu vaccine, that we often find lower uptake in socially deprived neighbourhoods amongst other minority groups, ethnic minorities and so forth. And unfortunately, there does appear to be at the moment some data is suggesting that we might be experiencing some inequalities within vaccine uptake. This is data from the beginning of April, and it suggests that we can see less inequalities by socioeconomic status amongst older age groups, which is obviously good. But once we start looking at lower age groups and all ages, we can see that there are significant differences between uptake in the least deprived areas compared to the most deprived. And this is something which I know we in the public health community are thinking about very carefully and trying to ensure that we don't end up with an inverse equity in terms of more affluent groups taking up the new technology and less deprived not benefiting, and more deprived people not benefiting at an equal rate. And of course, this could be very important when we're thinking about any potential 3rd wave. It could end up being concentrated in neighbourhoods that have lower vaccine uptake. So I just wanted to conclude by thinking about what we know about inequalities in COVID-19 and what we might need to do in the future to ensure that we're pandemic proof and that we're able to think about the health inequalities that may be increasing our adverse outcomes as a country. So we know from the data that health inequalities in COVID-19 are very clear. We can see them by terms of neighbourhood deprivation, in terms of region, in terms of individual occupation, and in terms of ethnicity. Together with colleagues, I've argued that these are related to a syndemic, where we have an interaction of the pre-existing social and health conditions, particularly the high rates of clinical risk factors in terms of long-term conditions within certain groups, and also their interaction both before the pandemic and during the pandemic with the social determinants of health, leading to pathways, at least 4, possibly 5 pathways leading to inequalities in COVID-19 outcomes. It's very clear that the vaccine rollout needs to reach everybody and that we need to draw on our knowledge from previous successful immunisation programmes to ensure that we have outreach to those that are most vulnerable. But perhaps most significantly for us as a public health community, as we begin to come out from the pandemic, as we become a post-pandemic public health community, we need to think much more carefully about inequalities in terms of NCDs and the underlying social determinants of health, and then think about the long-term action and what works in terms of reducing health inequalities in the conditions that could be underpinning the inequalities we see in COVID-19. And this is something which I hope we as a research community, including the School for Public Health Research, will take forward into the future. And just as a short plug, I do have a book that I've written together with my colleague from the United States, Julia Lynch, and my colleague from Scotland, Catherine Smith, that explores the argument presented today in more detail. And further reading on the data and maps that I've presented is listed here. Thank you very much, and I look forward to discussion and questions.